Good afternoon and happy Friday to all of you who have joined us. I'm Dr. Penny Sweetenberg Lee. I serve as the Director of Training and Alumni Development Programs for the Virginia Board for People with Disabilities. I am honored on behalf of our Executive Director, Terry Morgan, and our entire agency and board to welcome you to our statewide training on telehealth, accessing rural areas, rare diseases, and low incident populations. On behalf of our training alumni, and the training alumni are graduates of one of two of our flagship training programs, either our Partners in Policymaking training program or our Youth Leadership Academy, formerly known as Youth Leadership Forum. They are graduates of that program, and the mission of the Alumni Development Program is to provide advocacy trainings and continuing education workshops that are focused on the broader community in the Commonwealth of Virginia. In order for us to deliver these statewide sessions, it takes a whole lot of folks. And so we honor and acknowledge our production team members, headed, of course, by our Executive Director, Terry Morgan, our administrative team at Virginia Board, Henry Street and Tara Bethea, our communications team, headed by Miss Anita Ayers and Miss Brittany Hughes. And we welcome today our closed captioner from Virginia Relay, Miss Rochelle Hopkins. We are unable to deliver these sessions without challenges if we do not hire Boitnott Visual Communications, BBC. Today, our technician is Mr. Michael Boitnott. We also work very closely with the Commonwealth of Virginia, our state procurement office, and of course, DARS, who handles it directly with us and for us. We acknowledge, of course, our Mosaic interpreting team members that are always with us. Mr. Tristan Brown and Miss Felicia Smith are serving as ASL interpreters today. And our Director of Planning, Research, and Evaluation, who handles all of the evaluations, the surveys, the polls that we do at Virginia Board, but certainly that we do through this unit, Training and Alumni Development. And of course, I would be remiss if I did not acknowledge our team members in our unit, Ms. Christine Jeremiah, who is an outstanding team member and handles a whole lot of stuff for us in order to deliver this. So thank you all for what you do. We have already put into your face and into your presence a poll, and there are two polls that we will be launching today. The first one is for us to gather and understand who is here. And then the second poll will come at the end of the session. It is our session feedback poll that will go up immediately following our last presenter. And if there are accommodation requests for any alternate or alternative formats, we can drop it in the chat box or we can email it to you after the event. Today, we are going to introduce as our presenters, Dr. Helen Hughes, who is the Medical Director from the Office of Telemedicine and Pediatric Telemedicine, representing Johns Hopkins University, Johns Hopkins Medicine. My colleague that we're so excited and grateful to have join us from Virginia Board is Attorney Jennifer Krajewski. She serves as the Deputy Director of Public Policy and Legislative Affairs for Virginia Board. We also have with us today Dr. Rupa Valdez, who serves as an Associate Professor, School of Medicine, and School of Engineering and Applied Science from the University of Virginia. And coming to us this afternoon also by video presentation that Dr. Valdez will introduce will be Dr. Kathy Wimberly, the Director of the Mid-Atlantic Telehealth Resource Center, also located at the University of Virginia Center for Telehealth. Each of them will come and present their presentations. They will determine if they will take questions and answers following the presentations, but Christine Jeremiah, our staff member, will handle all questions that come in through the chat for each of the presenters. There will be a 5-minute Q&A following each of the presenters. And then at the end, we will come back and make some announcements about upcoming statewide workshops, and then close out with our poll. Let me now turn it over to Dr. Helen Hughes from Johns Hopkins Medicine, Office of Telemedicine and Pediatric Telemedicine, Medical Director.
Excellent. Thank you so much for the excellent introduction and invitation. I'm just going to share my screen. Wonderful. So I just wanted to start off with a little bit of background on the story of the telemedicine transformation that happened at Johns Hopkins in response to COVID. I am a general pediatrician by training. I practice in a Medicaid-focused clinic in Baltimore City. Pre-COVID at around 2016, I felt like telemedicine would be a great access point for my patients needing ADHD follow-up, mental health follow-up, asthma follow-up, et cetera. At the time, Maryland Medicaid and Medicare did not allow to bill for these services if patients were in their homes. So I had a pilot program with the Eastern Shore of Maryland where we were doing specialty telemedicine follow-up visits with the health department. And it had a lot of logistical challenges. I think we got 10 visits off the ground in a 10-month period. And so January 2020, I was thinking, man, I don't think this telemedicine thing's going to work out here. And then, in response to COVID, we had this kind of overnight acceleration. So we went from around 80 visits per month in January 2020 to in May of 2020, we have video visit volume in blue, telephone visit volume in orange. We had around 100,000 visits. And then we've gone to around 30,000 visits per month for the past 2 to 3 years. So telemedicine is about 12% of our outpatient volume, over 2 million visits to date. And it certainly is not a one-size-fits-all tool, but we do see a lot of our groups that deliver complex and multidisciplinary care using telemedicine. If we look at just telemedicine sensitive specialties, so if we take out lab and radiology, this looks at the percent of outpatient care that is telemedicine visits, 2021 in blue all the way to 2024 to date in gray. We're at about 12% in JHM total in the middle. But we have some groups that are still using a lot of telemedicine on the left: nutrition, psychiatry, neurology, neurosurgery, genetics, and critical care, which is often pre-op. We also see some groups like neurosurgery and neurology using more telemedicine this past year than they did in 2023. People with neurologic conditions often have driving barriers. You can't drive in the state of Maryland 6 months after you've had a stroke or a seizure. So we find a lot of our specialists using this tool for patients who have a long distance to travel, but also for patients who have barriers to traveling, even if they are relatively close to our services. Next, I'm just going to show a brief video. We recently hosted an advocacy event that I'm going to talk about later, and we created a video with the excellent help of a number of patients who've experienced barriers to cross-state telehealth. So I wanted to play about 4 minutes of the video to kind of set the stage for some of the next pieces I'm going to talk around telemedicine and equitable access. Oh, I need to unshare my slides because I didn't do the thing that I was supposed to do. Hold on 1 second.
So my name is Olivia, and I have been struggling for years with really severe treatment-resistant major depression.
Okay, my name is Kim Eba. I was diagnosed with crystal storing histiocytosis, one of 80 people in the world.
You have a secondary monitor.
All right, I promise it'll be worth it. Were you hearing the audio before?
Was hearing it, it just wasn't full screen.
Years with really severe treatment-resistant major depression.
Okay, my name is Kim Eba. I was diagnosed with crystal storing histiocytosis, one of 80 people in the world to be documented with that.
I'm Conrad Reynoldson. I am 38 years old with Duchenne muscular dystrophy. I'm Victoria, and I am currently in a multiple sclerosis trial, at Johns Hopkins. I currently live
So years ago,
a genetic disease that mainly affects the respiratory system and the digestive system. And for me,
I
went into the hospital, which was something.
In the United States, the practice of a healthcare profession is based on where a patient is located at the time the care is delivered. If I'm a physician and I'm seeing a patient via telemedicine, I have to be licensed where that patient is located during the visit. Now, pre-COVID, we actually did interact with patients across state lines. For telemedicine visits, there was this restriction, but for ages, we've been talking to the patients over the phone, we've been MyChart messaging with patients, and we did not ask where they were. But because of regulations around telemedicine visits, we needed to ask where they were before we provided care. During COVID, most states said, it's okay, you can see patients into our state and we won't do anything to you providers. So although we had a telemedicine office pre-COVID, we only had about 80 telemedicine visits per month, 800 total. All of a sudden, 70% of our outpatient visits by May of 2020 are telemedicine. That's 100,000 visits across Johns Hopkins Medicine in that kind of second month. It stayed at about 30,000 per month. So we've now crossed 2 million telemedicine visits. It's used across a ton of different specialties, from primary care to psychiatry, neurology, neurosurgery, genetics. It's part of the fabric of how we deliver outpatient. And then all of those waivers started to expire as state public health emergencies expired.
8 years ago, I was diagnosed with a very rare disease, and my doctors here in Asheville, North Carolina are very good. There's a cancer center, but they told me up front that I would need someone who specialized in my disease because they had read about it but had never treated it.
Specifically with this community, you know, we really rely on specialists, and they can be across the country anywhere.
To me, there's a difference between routine care, and these unique situations.
So I was diagnosed with cystic fibrosis when I was 3 months old. I grew up seeing my doctors like my entire life. So the fall of 2020, I went off to college and got super sick, developed pneumonia, and went into liver failure. I was at the local hospital who wasn't set up to treat me because of the complexity of my condition.
There are urgent situations across our country, and we hear from our patients frequently, where patients are really needing to receive cross-state care today, and they can't because of state-based licensure rules, including cancer care, transplant care, rare diseases, college student mental health, and clinical trials from an innovation standpoint. And so we really want patients to be able to connect with their providers and with their families, regardless of geography, so they can get the care they need.
Here we were, my father just having had his first stroke, he couldn't function.
Eve is in San Francisco, François in Baltimore, Philippe in Florida. So the only way that they could have been involved, and their involvement was critical, was by Zoom.
Given that it's specifically a neurologic illness, Mark had a lot of questions at that time, and we really had to reiterate the information. Each of us, kind of heard things in different ways and could interpret things a little bit differently and stress things differently. And so I think without all of us sort of being each other's backups, on Team Mark, I think it would be really difficult.
Not have to actually fly across the country and be present in the meeting, which is impossible, right? I mean, the fact is, it means that one of us is sharing the information with the.
Okay, so I'm going to chat the rest of the video just for the sake of time, and kind of go to some of the features that we've been working to make these tools continue to be accessible. Okay, so we have a video platform that's embedded in our electronic health record called Epic. We've worked hard to try to make these services accessible as possible for different populations. We have on-demand interpreter integration in our video platform for ASL as well as for Spanish language. And we have the ability to dial out to other interpreters on the left. We've linked with a couple of groups, one in Maryland and an advocate in North Carolina named Tony Davis, who's created some materials on the NC Department of Health and Human Services website for deaf, hard of hearing, and deafblind patients on how to advocate for themselves and access telehealth resources. We've also looked at some of the Baltimore levels disparities in accessing telehealth. We were lucky to have resources to create a telehealth equity dashboard pretty early in the pandemic in the fall of 2020, and have looked at some of the disparities in accessing video-based versus telephone-based telemedicine visits. We have researchers from across some of our schools who are interested in digital health and digital equity. And this is just a snapshot of the equity dashboard we have. This is from a couple of years ago, this snapshot, but it looks at the percent of total telemedicine visits we have in the upper left corner, and then the percent of those visits that happen via phone versus video. And then we have by different populations, race, ethnicity, preferred language, age, payer, the percent of encounters in that group that used phone in gray bars versus video in blue bars. So we see higher telephone visit use in patients who identify in the electronic health record as Black African American, Spanish versus English, older adults versus younger populations, and publicly insured patients versus privately insured patients. We still do not have great electronic health record data that clarifies patients' self-identified disability status, like the great poll you guys did at the beginning. So hopefully that's something we can add down the line as we have that more accurately in our electronic health record. And then we also have in this dashboard, looking by zip code, the percent of encounters in a zip code that occurred via phone versus video. If it's 100% video, it's dark blue. If it's 50% phone, it's dark orange. And so we can see this kind of butterfly pattern of disparities in Baltimore City, with East and West Baltimore having higher rates of phone encounters, which mimics a lot of other socioeconomic disparities related to redlining and digital redlining in those areas. We've also been lucky to be closely linked with the AAMC and have received awards regarding telehealth, something called the Telehealth Equity Catalyst Award. In 2022, we hosted a convening session with 76 local stakeholders about Baltimore City telehealth equity, and we made an asset map and some best practices documents. In 2023, we can continue those efforts with continued convening among a smaller group of interested parties, as well as refining our asset map. And then in 2024, we were really excited to get an award to make a MyChart simulation with Epic in English and Spanish, so that patients have the ability in a web platform to practice some of the processes in our electronic health record portal, like scheduling visits and entering telemedicine visits. And that's something we're working on now. This is a summary from that convening we did in 2023. We had lucky to have a visual note taker that kind of summarized some of the key issues, take away from the 76 people in the group. And we have a local group called EBDI that is the East Baltimore Development Inc., and they surveyed 178 local residents around some needs. And we saw that residents definitely wanted more affordable internet service. 66% were interested in some sort of training, and 55% were interested in free or low-cost computers. So those have been some of the access points we've been assessing with our local groups. We have made some positive momentum to date on some of those equity efforts and have had some challenges as well. We have a partnership with the Northeast Market in Baltimore, which is in East Baltimore, as well as Pratt Libraries in Baltimore City, to have some community-based outreach to community members. We've started these discussions with our electronic health record, Epic, about our simulation materials. And that needs assessment that I showed some interest from local groups about having more training. But we've also had some lessons learned. When we've done outreach in the community, we find that many community members may lack some basic tools they need to have MyChart training or telemedicine training, like stable internet and or devices to use. We also found that we needed ongoing community member feedback to sustain these efforts and improve them in the form of a digital equity advisory board, which we're working on forming. We also had some low participation in some of our community outreach efforts due to issues with foot traffic and privacy. At some of the outreach efforts in Northeast Market, we had no privacy, and so we had lots of people, but it was too loud and not private enough to have conversations about these tools. And then at the library, we were kind of in the back of the library in a room, and so we had pretty low attendance. We found that we really need to go to where patients are living, whether that's in where they live or in healthcare facilities and clinics. And then the final challenge was around the affordability and connectivity program sunsetting. This was a federal program that also often had state matching dollars, like in Maryland, there was matching dollars to provide free internet access. This was definitely an important program for both urban and rural residents, and was not passed with a spring with the budget approval. And so a lot of people who are relying on that for free internet access no longer have that access point. We've been lucky to establish a lot of local partnerships around telehealth access from our Baltimore City IT group. There's a group called the Baltimore Digital Equity Coalition. There's also a Maryland Digital Equity Coalition, a number of our local school organizations, as well as some senior living facilities and churches locally. We have collaborations with other health systems locally, like Kennedy Krieger and Baltimore Medical Systems, which is an FQHC. We've established some connections with local internet access and device access groups to see how we can refer patients to these community organizations for resources. And we together submitted a large grant last week to the National Telecommunications and Internet Administration. And we're hopeful if we get that grant that we can develop some processes for, yes.
Can you hear me? This is Dr. Penny. Our captioner is asking if you could slow down just a little bit so that she can catch up just a little bit. And the
absolutely, absolutely. My apologies, and I'm having trouble both seeing the group and seeing my slides. So apologies if anyone's been waving to me to do that and I wasn't able to see it. That's okay. Thank you so much. We submitted a grant to the National Telecommunications and Internet Administration. And the hope of this grant is to connect people in the healthcare setting with community-based resources for digital access. Part of that would include a group called NemiCore, providing refurbished devices that have disability accessibility settings. For instance, for someone who has low vision, the group will make sure the device has the settings applied to have large font or text-to-speech capabilities. So we're really excited about the potential to have a project where we can specify the resources to the needs of individual patients and community members. So that's some of the work that we've done locally around equity and access. But getting back to the video that I showed originally around rare diseases, and again, I will post a link in the chat at the end so you can watch the rest of the video. I know there's been a lot of advocacy at various state levels, and states are passing really helpful legislation. Virginia has a great law around established patients being able to receive telehealth from out-of-state providers if they saw those providers within 1 year in person. But we are finding it hard for patients who may come from all over the country to receive really specialized care, to maintain continuity of care. We receive, concerned emails from patients on a relatively regular basis, asking to have continued care with their provider. And a lot of that care is difficult to provide cross-state with the current rules in place. So we hosted an event last week in DC at the new Johns Hopkins Bloomberg Center, along with the Harvard Law School, on cross-state telehealth and specific use cases where there might be urgent needs and potentially bipartisan support for new federal lawmaking around this, including cancer care, transplant, rare diseases, mental health and clinical trials. So we were excited about how the event went. We had some action planning work groups as part of this, and hope to come up with next steps. So we're definitely happy to welcome anyone who's interested in this topic. And a huge thanks to the telemedicine team at Hopkins who makes all this possible. Happy to take any questions if I have time. Sorry if I was talking too fast. I'm not sure how I did on time. And then also Q&A at the end.
You did excellent on time. And it is now time for us to receive any questions. Christine, are there any questions for Dr. Hughes?
I have a question.
Yes, go ahead.
Is there any federal legislation to allow doctors to see patients across state lines?
So there is not currently for all patients, but there are 3 laws that do that for specific populations. One is for Veterans Affairs. That's existed since around 2017. That law states that any veteran can receive care from any Veterans Affairs provider licensed in any state. So it's essentially national licensure reciprocity for the VA. The second one is the Sports Medical Clarity Act, which says that a sports medicine doctor, for instance, an NFL quarterback's sports medicine provider, can travel with the team and provide care in whatever state they're in. And then the third is for military spouses. If you're a physician and you're a military spouse and you are relocated, you can use your home license in the state to which you are relocated. So the federal government has demonstrated when the stakes are high and there's enough momentum, it is possible to pass a law that would allow for more flexible cross-state care. But it's a challenge to balance the desires and needs of the state medical licensing boards with some of the needs of patients who need cross-state care.
Other questions?
Not at this time, Dr. Penny.
Okay. Dr. Hughes, I have one final question for you. One of the charts you showed was giving percentages of the concerns from the group that you brought together, 76 persons. And I think it said a high percentage of those were concerned about more training and the other being about more Wi-Fi access. I just want to acknowledge that it seems like we have the same issues no matter what state we are in. But has Johns Hopkins been addressing that? And if so, are there any suggestions, recommendations of how you guys are going about addressing those concerns?
Yes, so far the survey was actually conducted by a group called East Baltimore Development, Inc. So it was a community-based survey of 178 East Baltimore residents. We so far have been doing community-based training. That's what I talked about in the libraries and at a market near Johns Hopkins Hospital. We had planned to have a program to sign patients up for the affordability and connectivity program, but then that sunsetted. So we have applied for a grant for funds to try to provide free internet access and devices to community members through senior living facilities and patients from clinics at our clinics, Kennedy Krieger and Baltimore Medical System.
Thank you.
And I see a couple of quick questions in the chat, if it's okay. Hopkins, I believe now is starting to contract with Virginia Medicaid because we have a new site in Virginia. And so I'm happy to answer questions offline if there's any specific questions. And then the press would love to have any ideas about getting the press involved. We did invite some journalists to our event last week, and we're hoping that to be part of our action plans.
And we'll take this one final question from one of our training alumni, Catherine. We see your hand.
Hi, is there a way for us to help with any legislative pushes to allow telemedicine as it was allowed during the COVID emergency for those groups that are not in the three that you mentioned? I mean, we currently travel all over the U.S. for medical care for a rare syndrome, and I have to say it takes a toll on my daughter, our family, my work. And it was so helpful during the pandemic. And I know that it could really assist so many that are not able to travel for this specialized care.
Absolutely. So feel free to reach out to me directly by email. We are working with NORD, the national organization, the rare diseases and their advocacy group. And so our hope is we got this group of around 100 people together last week across healthcare, law, and policy. And we hope to kind of, to whatever new administration we have in January, kind of have a group of action plans that articulate what we think is possible. We have to balance large scope and impact versus the politics of possible and what is feasible. So I'm happy to talk offline. And I will chat the video so people can, after this, watch the rest of it.
Awesome. We have a few minutes to spare, and so I'm going to turn it over now to our colleague, Attorney Jennifer Krajewski, who serves as the Deputy Director of Public Policy and Legislative Affairs for the Virginia Board for People with Disabilities. Take it away, Jen.
Thank you, Dr. Penny. Good afternoon, everyone. Are my slides showing up okay? We're good? Perfect. I'm Jen Krajewski, Deputy Director for Public Policy and Legislative Affairs for the Virginia Board for People with Disabilities. So I'm here today to share our recent assessment on geographic disparities in healthcare and the barriers to telehealth here in Virginia. So my plan today is to give a high-level overview of our assessment findings and recommendations. And then if you're interested, you can find the entire assessment on our website, which I'll have a link to at the end. So as we start, just to give a little bit of background on how we got to this assessment, Virginia Code requires the board to assess and report on 2 areas of the disability services system within the Commonwealth each year. So our board selects the topics for these assessments. And in 2023, we released this assessment on geographic disparities in healthcare. So our purpose was to evaluate the geographic disparities in access to healthcare with an emphasis on broadband access and telehealth services, and make recommendations to improve that access. Our assessments are shared on our website. Hard copies are mailed to the governor, cabinet members, Virginia legislators, agency heads, partner organizations, and then we also share it on social media and anywhere else that we possibly can. So let's take a look at what we found. So Virginia is a geographically diverse state. We have big metropolitan areas, as well as mountains and coastal areas and very rural areas. The population of the Commonwealth is nearly 9 million people, 75% of which live in urban areas, while 25% live in the rural areas. So those individuals living in rural communities encounter barriers to access that are different from other areas of the Commonwealth. Some of these include access to transportation, access to broadband, and access to healthcare. So if we turn to focus on the profile of individuals with disabilities, there are over 1 million individuals with disabilities in the Commonwealth. In general, these individuals are poor and have higher rates of obesity, diabetes, heart disease, and smoking prevalence. In addition, individuals with disabilities are less likely to have a regular healthcare provider. So as I mentioned, For those living in the rural areas of the Commonwealth, they face a number of different access barriers. For individuals with disabilities living in rural areas of the Commonwealth, those barriers are often amplified. There are also some additional barriers that are unique to individuals with disabilities. So some of the barriers are listed here on this slide. We know that transportation is a well-known barrier in rural areas. In addition, there can be issues with caretaker availability to assist with appointments, the social anxiety of attending doctor appointments, or just the availability of a specialist within a reasonable distance. So before we get into a discussion of telehealth, I wanted to say just a few words about community engagement. You'll see throughout the discussion that local communities need to be a part of any solutions. One phrase that came up a lot, and you'll see throughout the assessment, is community anchor institutions. So this slide kind of shows some examples of community anchor institutions, such as schools, libraries, medical and healthcare providers, public safety entities, community colleges, and community support organizations. So these are trusted organizations that are active within communities and already providing important services. So let's look a little bit at the advantages of telehealth and how telehealth can help alleviate some of the barriers that we have discussed. So the United States Department of Health and Human Services defines telehealth as the use of electronic information and telecommunications technologies to support and promote long-distance clinical health care, patient and professional health-related education, and public health and health administration. Some of the benefits of telehealth include lower costs of healthcare, lower transportation costs, less exposure to communicable diseases, and decreased need for paid personal assistance services. So I just wanted to provide a little roadmap of where we're gonna cover today. Our assessment was broken up into these topics on this slide. We'll start talking a little bit about broadband availability and affordability, and then go into addressing some of the barriers to telehealth, including telehealth accessibility, digital literacy, and resource requirements. So first, we'll start with broadband availability and affordability. So the good news is that Virginia has a stated goal in place to reach universal broadband access by 2028. Virginia is looking to bridge the gap between demographics and regions with digital access and those without, which is also known as the digital divide. So this is particularly important as broadband access has become a super determinant of health due to its effect on other social determinants of health, including education, employment, and healthcare. So without access to reliable broadband, individuals are not able to access many of the resources that may otherwise be available to them. So when looking at access to broadband here in Virginia, as of the time of the assessment, there were 160,000 locations in the Commonwealth without reliable internet service. So the board worked with Virginia Tech to build off of work they had done previously with the Department of Housing and Community Development to create a map that shows broadband connectivity data with an overlay of disability prevalence data. It might be a little hard to see on this slide, but the areas of greatest concern for our purposes are those that are deep blue, as it shows in the top left corner of the key. These are the areas with high disability prevalence, but low broadband access. So if you're interested in data for your area, the appendix to the full assessment includes individualized maps by DBHDS region and community services boards. So as I noted, the Commonwealth's goal for broadband access is 2028. While that's only 4 years away, it is still 4 years away. In fact, I just read an article this week stating that 2/3 of recently funded broadband expansion projects are behind schedule. So that 4 years might be optimistic. So what can be done in the meantime to fill the gaps? In the assessment, we suggest that community options should be developed to allow access, including providing access points at frequently used and easily accessible community organizations, such as libraries, municipal buildings, and schools. The community anchor institutions can really fill the gaps. So to address this issue, we made the recommendation that the Department of Housing and Community Development should work with local communities to implement community-based options, such as the use of community anchor institutions to fill gaps in access in the near term and to provide access options for all. DHCD should target those areas with higher percentages of individuals with disabilities and low levels of broadband access. Okay, so let's move on and talk a little bit about telehealth and particularly the barriers to accessibility. Telehealth has emerged as a transformative force in healthcare today. It provides greater opportunities for convenient and accessible medical services. Telehealth accessibility refers to the extent to which individuals can readily and effectively access and utilize telehealth services. So the first thing we looked at in this area for the assessment was what is already required. Federal law, including the Americans with Disabilities Act, requires that telehealth must be accessible by individuals with disabilities, just as an in-person visit would be. While this isn't new, the explosion of telehealth use has brought to light this issue that many seem to be unaware of. So in an attempt to better educate providers, we recommend that the Virginia Board of Health should create and implement a plan to educate telehealth service providers on current laws and standards for accommodating individuals with disability, concurrent with or consistent with its authority under the Code of Virginia. So the plan would encompass various aspects, such as allowing extra time for appointments, ensuring the availability of suitable platforms that accommodate interpreters and other necessary support, and enabling a remote login from a third location. So let's take a moment and look at some of the barriers to telehealth from both the patient and provider sides. For patients, technology can be a huge barrier. Of course, there's the access issues we've already discussed, but there can also be difficulties with the interface or the platform used for telehealth. For example, individuals with cognitive impairments often find that platforms used by healthcare providers are difficult to navigate. In addition, there can be physical barriers to telehealth, such as mobility impairments. For some, the movements or positioning that may be needed by a provider for a proper exam may be difficult for them to achieve. Another frequently mentioned barrier is cost. On a positive note, Virginia's Medicaid program has allowed for flexibilities put in place during the pandemic to remain, which allows for reimbursement for telehealth services. So this does help to decrease that cost barrier. Looking at the provider side of telehealth, providers have their own barriers. Virginia Telehealth Network conducts an annual survey of providers regarding their use of telehealth. And overall, the 2023 survey indicated that provider confidence is growing. But the survey did show some areas where providers believe there's room for improvement. Once again, broadband access tops the list. Some other provider barriers include access for patients to devices required to participate in telehealth, platforms that allow for interpreters or third-party assistance, and training for providers and staff. The pandemic threw healthcare providers for a bit of a loop. requiring them to move to telehealth with little to no training for themselves or their staffs. So this lack of training leads us to our next key finding of the assessment, which is that training in telehealth best practices is needed for providers and staff to equip them to meet the growing demand for telehealth services. And our recommendation is that the Virginia General Assembly should direct the Virginia Department of Health Professions to establish and implement a continuing education requirement for healthcare professionals on best practices for providing telehealth services, including specific information on telehealth and individuals with disabilities. In addition, the importance of those community-based solutions cannot be overemphasized. Community-based solutions to address barriers are used throughout the country and can be used as models to create community-based solutions here in the Commonwealth. Organizations are creating innovative partnerships to get healthcare services to those who need them. Our assessment highlights some examples of community-based solutions that have been implemented. For example, in Delaware, the public library system has partnered with various healthcare systems, health-related nonprofits, and the state's Department of Health and Social Services to create telehealth within the libraries. Each library has installed soundproof booths equipped with UV sanitation and HEPA filtration. Each booth is wheelchair accessible and can seat 2 to 3 people, and each booth contains the technology needed to access telehealth services, and library staff are available to assist with any issues. In Tennessee, Dollar General has partnered with a company called DocGo to pilot mobile healthcare in Dollar General parking lots. Patients meet with an on-site staff person who connects them via telehealth with a physician assistant or a nurse practitioner. In Roanoke, Virginia, there is the LIFT Center. LIFT stands for Local Impact for Tomorrow, and the center is a private-public partnership between Carillion Clinic, Delta Dental of Virginia Foundation, and Freedom First Credit Union. The LIFT Center is attached to Fallon Park Elementary School and has 3 exam rooms, a lab, and a conference room. It's staffed by a registered nurse and a pediatric nurse practitioner. It's also equipped with everything needed for telehealth, and the clinic allows for school nurses to be able to refer students for symptoms that arise during the school day when they're already in school instead of having to move to another location to see a doctor. There's also a veterans program in use across the country called Project Atlas. Atlas stands for Accessing Telehealth Through Local Area Stations. And this is a public-private partnership between the U.S. Department of Veterans Affairs and various private non-governmental organizations. The program provides space and needed technology for telehealth appointments at enrolled medical centers. So the VA partners with organizations like the American Legion, VFW, and even Walmart to provide these services. So programs like these show that it's possible to collaborate and create partnerships to make a difference. So the board recommends that the Virginia Broadband Advisory Council should study the innovative partnerships being developed in other states and use them to develop recommendations to the governor's office for consideration for the state fiscal year 2026 budget on how Virginia can expand broadband access through community partnerships. Okay, back to our roadmap, and next up is digital literacy. So digital health literacy is an individual's ability to understand, use, and navigate telehealth technologies and services. A discussion of digital health literacy includes several issues, including technology proficiency, usability of telehealth platforms, digital communication skills, and access and equity. Ongoing education and support is essential to ensure equitable access to telehealth. So one overarching issue that came out through researching for this assessment is a lack of trust by many who live in rural communities. It's a huge barrier that needs to be addressed in order to improve digital health literacy. So resources are available to teach digital literacy skills. For example, the U.S. Department of Health and Human Services, through the Health Resources and Services Administration, has created the Rural Health Information Hub. So the RHI Hub contains information on rural health issues as well as digital literacy. But it is important to include community organizations in planning for dissemination of materials or development of training programs. So our key finding in this area was that digital health literacy is a major barrier to the use of telehealth, particularly in rural areas. Many individuals in rural communities lack trust in systems created without their involvement. Any outreach must be done through local community organizations and individuals who live in the community, giving them a unique understanding of barriers faced in rural areas. The importance of community involvement should be included in any planning to improve digital literacy and access to telehealth. In 2021, the Department of Health led the effort to develop Virginia's state telehealth plan. The plan promotes the use of telehealth. The Virginia Telehealth Network is currently working with the Department of Health to update that plan to reflect changes in the telehealth landscape. We believe this is an opportunity to ensure that communities are involved in promoting the use of telehealth and providing assistance in the area of digital literacy. So for that reason, we recommended when updating the state telehealth plan, the Virginia Telehealth Network and the Virginia Department of Health should incorporate strategies and a plan for collaborating with community partners to offer digital literacy services to individuals who require them. Okay, so the last piece of our roadmap is resource requirements. So when it comes to technology resources, access, including affordability of the technology needed to participate in telehealth is a barrier for many. There are a number of programs in existence to assist with technology needs, including the Virginia Assistive Technology System. The Virginia Assistive Technology System works to ensure that Virginians of all ages and abilities can acquire the appropriate, affordable, assistive, and information technologies and services they need to participate in society. The Virginia Assistive Technology System provides services through 3 different programs. They have the Information and Assistance Training and Technical Assistance Program. They have the Assistive Technology Device Demonstration and Loan Program, and the Assistive Technology Device Exchange and Reuse Program. So expanding programs like this could assist more individuals in receiving the technology required and the training in how to use it. So our final 2 recommendations seek to increase funding and awareness about these types of programs. The first being that the General Assembly should establish a work group to identify suitable sources of new funding or additional funding for programs that supply essential technology equipment and training in its use to support access to telehealth. And also, when updating the state telehealth plan, the Virginia Telehealth Network and the Virginia Department of Health should include strategies to increase access to resources, including using the Virginia Assistive Technology System and the Assistive Technology Loan Fund Authority. So that is it for me. I hope that if you're interested in some of these findings, that you'll take some time to review the entire assessment, which can be found at the board's website at the link shown on this slide. And I've also provided my email address if anyone has anything they want to follow up on. So thank you for your time and your interest today. And I can try to answer some questions, or feel free to email me and we can touch base.
We do have a few questions, Jennifer, that you may or may not be able to answer.
We'll give it a shot.
Okay, wonderful. So the first question is telehealth a billable service in home and community-based waiver program?
That is going to be a question that unfortunately is beyond me. I did not dig that far into those things, and I get kind of lost myself when I go there.
Okay, fair enough. Next question. Is there a way for states to get funding again for the Affordable Connectivity Program?
That is an interesting question. That actually was also part of our assessment, which I didn't cover today because the program is now defunct, at least temporarily. I know that President Biden was very interested in extending the program, and I've heard talk that maybe at some point, but that's kind of beyond our purview here at the state level. That is definitely a congressional decision, but I wouldn't say with 100% certainty that it's gone. I would not be surprised if it comes back down the line, hopefully sooner rather than later.
Okay, excellent point. Thank you very much. And the next question is there legislation pending in the Virginia General Assembly to fix and or proposed legislation to fix the issues within your presentation?
Well, we haven't seen anything yet. We're early for the next session yet, but we're hoping, as I said, all the legislators received copies of the assessment. So we're hoping that maybe we can get some interest and that legislators will reach out to us and we can make something happen.
Wonderful. And a follow-up to that, very quick. If you're logging into a public area, are privacy and safety protocols being considered given the delicate nature of the medical profession?
I think that is actually one of the largest issues which kind of prevents some programs from happening, is making sure that spaces are private, that all information remains so. But there were a couple of the examples I talked about, the Delaware library system. They've really found a way to make things accessible for folks and keep privacy in mind. So I think it's possible, but it definitely needs to be a big piece of the conversation.
Okay, wonderful. And then I do see a question from one of our training alumni, Miss Marlo Dean. If you'd like to unmute and ask your question.
Yeah, so it's not really, I guess it is a question. So we're talking about the extending that program that we had during the pandemic and the access for broadband and things of that nature. But these companies have their own little pot of money for persons who have a little trouble affording, because honestly, it is really expensive. I pay $80 a month for Wi-Fi. And the company I left, Cox, they were charging me $150 just for Wi-Fi. And it's ridiculous. They do have these programs when you decide that you want to leave that they tell you about, right? So why not just tap into that and partner with that, whatever that entity they have going on, to try to keep you when you want to leave and keep the program going longer.
Yeah, I think that's actually a great point. In our assessment, we do have a table that includes some of those programs. Certainly not an exhaustive list, but a list of some that people can use in replacement of the federal program. The federal program, I think, was probably the best of them, but there are definitely other options out there that I think people should look into. So check out our assessment and you can see the whole table of different programs that we found.
Thank you.
Jennifer, I have a question, and perhaps you and Terry, our executive director, can answer. Just for informational purposes, I wonder if you could share with our audience the process that Virginia Board goes through to conduct these assessments. Are vast, and it takes a whole lot of collaboration, commitment. What is the process? And then when you share with us that you've made these recommendations, How have you gone about communicating with the groups, and or how long does that process still take to bring them along on the recommendations?
Well, that's just a loaded question. So I'll take a stab at it and then Terry can fill in any of the blanks. So it really is kind of a year-long process because we have 2 of these assessments to do each year. I work on finding all of the folks I can that have interest and knowledge in these areas. I certainly did not have a lot of background in telehealth or broadband before I started researching this. And then once we have a draft put together, it goes through many review processes, but it also goes to our board. We set up an ad hoc committee who takes a deep look at each of the recommendations, makes any edits that they think are necessary, and then it's presented to our full board for their approval. Once the full board approves it, then we get it all set up. We get it on the website. We get it printed, get it off to the legislators. And then that's really when the advocacy piece starts. We hope that people reach out to us. If we're meeting with legislators during the session, we may bring them extra copies. We may raise it as an issue to them to see if they would be interested in it. But it's really about getting the word out there.
I'm happy to fill in some blanks. I'm dog sitting. So if you hear a dog, that's why I'm like telling her to be quiet. Thank you for the question, Penny. We have a really lengthy process with our assessments, as Jen alluded to. One of the things we've been doing, much more intentionally in the last few years is really trying to hear from people with disabilities and families about their experience with specific services. Having focus groups, doing interviews, doing surveys to really understand what the experience is with specific services and supports. That wasn't probably quite as detailed in this assessment because this assessment was different. But with our assessment of consumer-directed services, our information access work has been really focused on a human-centered design approach to our recommendations and our advocacy around building systems and supports that really meet the needs of people, not only their needs, but their expectations. People with disabilities and family members, should expect good quality services and supports, options, choices, that they can provide informed, that they can make informed choices. So we've really been focusing on understanding the experience directly from people and also providers, the provider community, community services boards. So we've been doing a lot of work in that area with the development of our recommendations. And then we use those recommendations as an advocacy tool. We've had some good success with a number of our recommendations being adopted. And a few of them, are, with the CD services assessment, the bundling of assistive technology and electronic home-based support, to make that service, instead of $5,000 individually, a $10,000 bundle to provide more options and choices if you're on a waiver and you have access to those services. That was one of our recommendations. Continuing to allow legally responsible individuals to be the provider of consumer-directed services. So we have a lot of, recommendations that, speak to what we hear people with disabilities and family members want and need. So that's, really our priority with the assessments. And we also work very closely with agencies. As Jen said, the assessments are required by the board in the Code of Virginia. And that involves getting data and information from agencies. So we work closely with specific agencies to get information and data. So the assessments are informed by that information and data, and trying to bring a different lens to understanding the landscape, such as the maps that Jen alluded to that are in the assessments by CSB, that are really information that hasn't previously been available, to really look at disability prevalence overlaid with broadband access that's usable, so we could really understand where the disparities lie.
Awesome. We have about 2 minutes, so Justin, we'll take a quick question, and then we're on time to move to our next presenter.
I know. Is this going to impact the waiver and the waiver slots that are coming down the pipeline?
Jen, you're on mute.
Muted. This shouldn't have any particular impact there.
And if I could just add, I know there was a question about telemedicine, sometimes referred to as telehealth in the waivers, and there are a number of waiver services that can be provided using telehealth. So, I'll look for a link on the DMAS website, but that is an option for a number of waiver services that people may want to be aware of.
Thank you. So we are just so excited to have these expert presenters and these folks who are working in this area. Dr. Helen Hughes has done a magnificent job this morning and this afternoon. And now Jennifer, and now it's our privilege and honor to introduce Dr. Rupa Valdez, who serves as an associate professor, School of Medicine and School of Engineering and Applied Science at the University of Virginia. I will give it to her. It is 1:05, so she has an additional 5 minutes. We'll go till 1:45. Thank you.
Thank you. So good afternoon, everyone. Thank you for sticking with us into the second hour. And thank you to Dr. Sweetenberg-Lee for all the effort I know you have put into organizing this session for all of us today. So my name is Rupa Valdez. I use she, her pronouns. And as a visual description, I am a South Asian woman with curly, long black hair. I am wearing a navy blue shirt and sitting against a lilac colored wall in the back. I myself identify as disabled and I have some vision related disabilities, which is why I am not on camera right now. And I sometimes like to talk to whoever's in the audience that you can think of this as a podcast with some visuals. So before I dig into my talk, I'm actually going to begin with a video talk by Dr. Kathy Wibberley, who is a colleague of mine at the University of Virginia. She is, sorry, I'm going to pull up my note sheet here. So she's the director of the Mid-Atlantic Telehealth Resource Center at the UVA Center for Telehealth. And Matrix has a multiple regional, overall, right, the Telehealth Resource Center has multiple regional branches, including the Mid-Atlantic branch. And this branch covers Virginia, West Virginia, North Carolina, Pennsylvania, Maryland, Delaware, Kentucky, New Jersey, and the Washington, D.C. area. So in this short video, Dr. Wibberley is going to provide an overview of the various functions of MATRC, talk about the activities and resources available, particularly as related to telehealth policy and related to technology. And then finally, she concludes with a discussion about how the MATRC has focused on expanding their practices as it relates to accessibility and inclusivity for telehealth. So with that, Michael, may I ask you to cue the video?
Hello, I'm Kathy Wibberley, Director of the Mid-Atlantic Telehealth Resource Center at the University of Virginia Center for Telehealth. I regret that I can't be with you live today, as I'm currently traveling back to Virginia after presenting at another conference in Kentucky. The National Consortium of Telehealth Resource Centers consists of 12 regional and 2 national telehealth resource centers. The Mid-Atlantic TRC is one of the 12 regional centers serving the 8 dark purple states plus DC for a total of 9 areas as shown on the map. Virginia is one of the states we serve. TRCs provide support across all 50 states and U.S. territories, including Guam and Puerto Rico. TRCs are funded by cooperative agreements with the Health Resources and Services Administration's Office for the Advancement of Telehealth. Our mission is to help develop sustainable telehealth programs to improve access to quality care, with a focus on rural, underserved, and vulnerable populations. All TRCs can be accessed via the consortium website at telehealthresourcecenter.org. The consortium hosts a free educational webinar every third Thursday of the month from 2 p.m. to 3 p.m. Eastern Time. Recordings of past webinars are available on our YouTube channel. The consortium website also offers an array of valuable telehealth resources. In addition to the regional TRCs, there are 2 national TRCs. One focuses on telehealth policy. On their website, you will find an extensive database of federal and state-level telehealth policies by topic. They also produce reports and briefs to help you navigate the complex policy landscape around telehealth. The second national TRC is the Telehealth Technology Assessment Resource Center, or TTAC, which provides toolkits and resources to help you evaluate different telehealth technologies and define your needs. As many of you know, not all technologies are designed with accessibility or human-centered design in mind. TTAC can help you navigate some of those complexities. Let me now introduce you to Matrix. Each regional TRC has its own website, and ours is matrc.org. We've added a chatbot in the lower right-hand corner, which does a great job answering common telehealth-related questions. Try it out and let us know if something doesn't work to your liking. Our website addresses many frequently asked questions about telehealth. It also features sections on telehealth best practices, including videos, downloadable handouts, and more. I want to highlight an important issue, and I know that it's near and dear to all of your hearts. The pandemic's rapid adoption of telehealth revealed that certain populations who could benefit most from telehealth, such as people with disabilities, were often left out. We've developed resources to help providers ensure equal access and follow best practices in telehealth for people with disabilities. While most of our resources are provider-focused, we've also created resources for patients. At the bottom of our Preparing for a Visit page, we offer several handouts for patients with disabilities, including a downloadable, fillable communications accommodations letter for patients who are deaf, hard of hearing, or deaf-blind. Older adults were another population that underutilized telehealth during the pandemic. We partnered with West Health Institute to create guidelines for age-inclusive telehealth best practices. Many of these guidelines translated into resources, and these resources overlap with resources for people with disabilities. Additionally, we worked with the Virginia Department of Health to create the Virginia Impact Initiative, addressing the needs of those living in congregate care settings like skilled nursing facilities, rehab facilities, and adult day programs. Matrix has a small team of 3 staff members, but we're backed by a large network of consultative service partners, allowing us to offer a wide range of expertise. Most of our services are free, ranging from answering basic questions like me, I'm probably the one who would answer most of the basic questions, to helping clinics and providers develop their telehealth programs from a very extensive hand-holding perspective. We offer many ways to get involved, including following us on social media, subscribing to our newsletter, submitting posters for our conferences, and nominating individuals for our annual awards. Here's my contact information. Feel free to reach out if you need assistance with telehealth, or if you know a provider who could benefit from making telehealth more accessible for you or for others you know. Thank you for the opportunity to introduce you to myself and to the TRCs.
Wonderful. And please do reach out to Kathy if you have any questions that she might be able to help answer. She's also a great resource to connect you with other resources that are a part of the MATRC. So with that, I can jump into my slides. Perfect. So I'm going to begin more broadly with a conversation about health equity and lessons learned as related to telehealth in the few years after the pandemic. And then I'm going to focus on more specifically on the disability community as a health disparity population and discuss telehealth specifically as it relates to the disability community. Next slide, please. So I'm going to begin by talking about early lessons from PCORI, or the Patient-Centered Outcomes Research Institute. And this was a summary of the 35 studies that they had in their portfolio of studies they funded in terms of what they learned about telehealth as it relates to meeting the needs of health disparity populations. So in this context, they were talking about racial and ethnic minority groups, people with low socioeconomic status, underserved rural communities, social and gender minority groups, and also people with disabilities. So So I pulled out 5, their kind of main 5 themes they came up with through this assessment. So the first was the importance of delivering telehealth through trusted intermediaries. They talk in particular about the importance of responsive technical support and also about the benefit of working specifically with community health representatives, community health workers, and patient navigators as a part of meeting the needs of health disparity populations. A second theme was around partnering with payers to expand telehealth reimbursement. A third that we've talked about some today already was ensuring confidential sharing of private information. And particularly, they discussed this in the context of the HIPAA flexibilities that were in place. A fourth part here is around the importance of patient-centered design. I might reframe that around human-centered and thinking about an individual not only as a patient, but the full dimensions of their everyday life and the importance of involving them throughout the design process. I'm going to dig into this part of this idea of human-centered and patient-centered design a little bit more towards the end of my talk. And the last theme here is around the cultural tailoring of telehealth solutions. And here, I'm going to direct your attention to this. It's kind of like a pie chart, I guess. And this is from a culturally informed design framework that I published years ago when I was a graduate student, but I always think it continues to apply. And what I like to think about is the 4 spaces of technology design where we can think about creating cultural tailoring. So the first is this around technology platform. So we've talked a lot today about digital divide, differential access to broadband. And we know on average about 15% of US adults only access the internet through smartphones. And we know, of course, that this is a much greater number for individuals who are part of health disparity populations. There's also disparities in wearable devices that are often linked to telehealth provision. Certainly in the terms of functionality that is presented, that's one other space. User interface. So when I'm talking about user interface, I'm thinking about things like what are the colors that we use to represent different ideas? What are the types of icons that we use? What does the navigational structure look like? And this is in part thinking about how do we, in different subgroups, think about how information should be grouped together, or what do we associate with other ideas for when we're looking for information? And the last example I'll give here as it relates to content. So if we're thinking about telehealth broadly, beyond interaction between clinician and patient is synchronous, but more broadly about the type of services we provide through a digital medium, we might be providing significant content in that way. And so sometimes the example I like to give is from my own personal experience. I was diagnosed with gastroesophageal reflux disease or acid reflux when I was in my early 20s. And I remember getting the feedback that I should not eat spicy food. And I remember thinking, I think I know what the clinician means by this, but as a woman who grew up from a South Asian household, I said, I'm not quite sure how I communicate that to my family because their idea of what is spicy might be quite different than what I'm being asked to do. Next slide, please. So one more place I'm going to draw some early lessons is from a review of about 50 primary care providers across 47 federally qualified health centers. And here the focus was on, again, I'm pulling out 6 themes here. So one was about reducing transportation burden on patients with disabilities and their families, and strategies to serve, here they're pointing out specifically serving deaf and hard of hearing patients through telehealth. I'm going to talk about a few of these a little bit later, again in detail. The importance of providing telehealth for patients with a language preference other than English. And here there's some discussion about some of our lack of capability to meet those needs sometimes, particularly for languages that are not spoken as frequently. The importance of using telehealth to improve access to mental health and behavioral health services. And the importance of improving the visit quality by educating patients about what to expect when they enter a telehealth encounter. In addition to this, just to pull a few ideas from some other studies that came out during this time that were reflecting on how we improve the ways that we provide telehealth to health disparity populations. was the idea that equity should be a quality metric in our assessment of telehealth and telehealth-based interventions. The importance of community partnerships is foundational, again, to creating responsive solutions. And the importance for all of us to be advocates for improved digital infrastructure. This last one that I actually had at the top of the slide was about adopting telehealth strategies to meet the need of unhoused patients. And this gets a little bit into what some of my colleagues talked about earlier this afternoon, but the importance of meeting people where they are. So this idea that telehealth here could be provided in shelters, that it could be provided in vans, and really, how do we bring telehealth to where people are currently located? Next slide, please. So here's just a few pictures. The one on the left is from pre-pandemic. I wanted to show what the VA was doing pre-pandemic. This is the Telehealth Education Delivered, or TED. And so one of these interventions that happened early on. On the right, top right, you see this is a Royal Philips intervention. It's called the Virtual Care Station that was made available in town halls, in universities, in libraries. And here in the description of this, they talk very specifically about trying to keep some aspects of accessibility in mind. So trying to set up a space that allows for mobility aids, that allows for service animals, and trying to think more purposefully than it sometimes is done in terms of that. And then we talked a little bit earlier this afternoon about Dollar General. And so and the idea that telehealth there was partnership there where telehealth was being offered in the parking lot of the Dollar General. And certainly Dollar General is one of the largest retailers by number of stores. And 80% of their stores are in locations where the population is less than 20,000. So of course, where healthcare access is more challenging. And I might just I think there's a lot of potential benefits of this type of partnerships. I want to trouble it a little bit by saying part of the reaction amongst people in these communities was that there's also stigma associated with seeking care at Dollar General. And so for us, as we're designing these solutions, to really be thinking through some of the unintended consequences or barriers that might still exist. And another challenge that came up in this context was, does this democratize healthcare more broadly speaking in terms of creating access, or does Dollar General itself can that create harm for communities? So some discussion around the trouble, for example, with safety for employees and complaints in that space. So again, just saying there's a lot of ideas in terms of what is promising, but for us to think, I'm trained as a systems engineer, so I'm always thinking about the broader system in which we're intervening and the importance of us attending to these potentially unintended consequences of the solutions we develop. Next slide, please. So I'm going to move to a discussion of the disability community as a health disparity population and talk through the dimensions of that. Here I wanted to point out, which may be familiar to many of you, but that the National Institutes of Health designating people with disabilities as a health disparity population in the fall of last year. And of course, this has led to many more resources being directed from a research standpoint into thinking about the needs of our community and how we address those needs more broadly. So when I talked about those different health disparity populations up front, certainly the other four I talked about earlier on have been designated from a research standpoint by the NIH as health disparity populations. And it took much advocacy and activism on part of our community, of course, for the NIH to expand the designation to include the disability community. Next slide, please. So the other thing I'd like to do by way of introduction into this space is to introduce the term structural ableism. So it's a form of structural oppression experienced by the disability community. We can also think about this as that ableism in particular is bias against or the devaluing of disabled people. And then the idea of structural ableism to take that more broadly to things like infrastructure, things like technology. And so I have the definition here, but I'm going to read it out loud for anyone who would need that as an accommodation. So a complex system of hierarchical and discriminatory processes, policies, and institutions that privilege and prefer able-bodied people, fail to represent or meaningfully include disabled persons' voices, and are grounded in a network of ableist beliefs and practices that maintain and reproduce unequal outcomes for disabled people and benefit able-bodied people. So this is a term that had not a lot of, at least in the scientific literature, there was only 5 articles a couple years ago that came up, or last year, when you search for this term. So a fairly new term that parallels some of the other things that we certainly talk about in terms of forms of structural oppression. Something that I've written about with a co-author of mine, Dr. Bonnie Sweener from Johns Hopkins, and a space that we're doing some work now to try to create measures of structural ableism within healthcare that includes technology and telehealth as a part of that, as a means of assessment for us to understand how our interventions shape the experiences more broadly for disabled people. Next slide, please. So I want to talk about the different dimensions of this in the context of health and healthcare. So I'll start out just by talking broadly about the disparities the disability community faces in terms of social determinants of health. And again, these statistics might be familiar to some of you. Some of these might be new to some of you. But I like to set this stage, think about the complexity of what we're thinking about here when we're talking about intervening. So from a social determinants of health perspective, certainly this exists across criminal justice, education, employment, transportation. And so just as a couple of examples, that nearly 2 in 5 imprisoned individuals have at least one disability, that 34% of people with disabilities have inadequate transportation to healthcare compared to 16% of adults without disabilities. Next slide, please. There are specific barriers to healthcare access and disparities in health outcomes. So 1 in 4 adults with disabilities do not have a usual healthcare provider, and 1 in 4 adults with disabilities have an unmet healthcare need because of cost in the past year. So thinking again about this idea of intersectionality and disability and socioeconomic status. And then certainly adults with disabilities are more likely to have obesity, to smoke, to have heart disease, to have diabetes. So as we're thinking about interventions for some of these more common chronic health conditions, thinking specifically about the needs of the disability community as it relates to these interventions as well. Next slide, please. I'm just going to go through a couple more. So one is around educational and attitudinal barriers. As many times as I've read these statistics, they always kind of leave me thinking and reflecting, and because I still find them quite striking. So that only 41% of US physicians reported that they were very confident about their ability to provide the same quality of care to people with disabilities. And only 57% of physicians strongly agreed that they welcome people with disabilities into their practices. Next slide, please. And this last slide, in terms of going through this, relates to physical barriers. So over 75% of individuals with disabilities report experiencing barriers that impede them from using health care and wellness services. Of course, at 36% of clinic restrooms do not meet ADA requirements. Next slide, please. So I want to point out, I mentioned this just briefly a bit earlier, but I want to highlight or underscore that discussions about disability must be viewed as intrinsically linked to discussions about other underserved and marginalized communities. I do think sometimes when we think about health disparities and we think about rural communities, the disability community, racial and ethnic minority groups, that sometimes we have a tendency, as we do in a lot of other spaces, to create silos in terms of the conversations that are happening. But certainly as we are talking about the disability community, disabled individuals are overrepresented in terms of older adults, veterans, people of color, and rural communities. So if 1 in 4 generally in the US of adults are disabled, that number is 1 in 3 in rural communities. So just wanting to underscore the importance of always keeping multiple dimensions of marginalization in mind as we think about how we intervene moving forward. Next slide, please. So I think about the setup that I did as we moved into this part of the talk as really highlighting the ethical imperative to be attending to telehealth and the disability community And then I want to bring up some other imperatives. So one, of course, is a legal imperative. And we've been talking about this some already today. But certainly, I think in this audience, many are familiar with the different legal framework that we have for trying to ensure that telehealth is accessible, both across the Rehabilitation Act, the ADA, and the ACA. And yet, right, we know that from, if we look at like the 97% of the top 1 million web pages, that the average website of those, that homepage of those websites has an average of 51 barriers. And I think this is really important to underscore. So even though we have this legislative framework, even though we have the web content accessibility guidelines, in many cases, we are still not creating accessible solutions. And not only that, but significant number of barriers. And so certainly,
Dr. Roop, I'm wondering, did your PowerPoint, Michael, did it go away or did we close it? It disappeared, Dr. Bell.
I'm not running it, so I'm
talking to Michael now.
I believe my internet blipped out here.
Okay. Yeah. We're having some bad weather down here.
Yeah, me too, where I am. So I totally understand that.
He's pulling it back up.
So this is the last
Okay.
slide. This is the last slide I was at.
Yep, I'm still on that slide, so I think you're good.
Okay.
Okay. Perfect. And so I guess I'll wrap up the slide by saying, we still, of course, have many challenges that remain. We don't have a great enforcement mechanism for ensuring that our digital solutions, our telehealth solutions are accessible. We still have, I think we're certainly getting better, right? There is movement in this space, but there is still significant progress to be made in terms of clear and comprehensive standards for accessibility. And as an engineer, I say that, in part that the burden is on those of us who are engaged in the design of these solutions, those of us in the clinical spaces and community spaces that are implementing these solutions, to really try to move this forward as we're trying to move, right, kind of the legal aspect of this forward as well. Okay, next slide, please. So the last bit of this, I talk about this as just good design. So the design imperative. So universal design is a design framework that, of course, comes out of the disability rights movement. And the idea here is that we're trying to design products and systems and environments to be as usable as possible by as many people as possible. And the other way to think about this is creating alignment for people's needs in the moment. So for those of us who get to be in conversations where we're advocating for better telehealth solutions, one way that I have tried to do this is by talking about it in the context of universal design. So I myself have limited dexterity in my upper extremities. Sometimes if there are smaller buttons on a phone or and anything with a touch screen, it can be really hard for me to engage in the movement to click that button. And this may be true for me pretty much all the time, but for somebody, I grew up in Wisconsin, so when you have cold hands, for example, that can also be true, that a bigger target is more helpful. And so trying to think about this in terms of, yes, we're trying to create more access for the disability community, but we're also trying to create more access for everyone in moments where somebody may also have the need for that type of accommodation. Next slide, please. So I'm going to dig in a little bit to evaluating telehealth for the disability community and talk about a few different components of how I see that in terms of a somewhat holistic framework. Next slide, please. So we've, again, dug into this a bit earlier this afternoon, but certainly one of the potential benefits of telehealth for our community is reduced what I call patient work, or so the effort of being a patient and engaging in attending to one's health and well-being, and as a part of that, accessing healthcare. And so this patient work may be the context of being in the clinic itself, but certainly there is significant patient work for attending an in-person appointment that is not true for a telehealth appointment. And this might be that related, for example, to coordinating transportation. Certainly that's true for me. I haven't been able to drive in over a decade, and so coordinating transportation is certainly part of the patient work that for me gets reduced. The second is the opportunity to avoid inaccessible clinical spaces. So as we saw earlier, many physical environments in the healthcare setting are not accessible to everyone. And this can certainly be as related to mobility or wheelchair use, but it can also be sensory in nature in healthcare settings where there are a lot of fluorescent lights, for example, and certainly in terms of sound and other types of sensory stimuli. So home might just be a more accessible place. It might be more emotionally comfortable for many people as well. And certainly also less exposure to communicable diseases for those who are immunocompromised. And then lastly, the potential for improved healthcare access and quality in terms of reduced wait times and improved access to a wider range of clinicians. Next slide, please. Getting back to this idea of unintended consequences, so certainly one unintended consequence could be further exacerbation of inequities faced by people with disabilities. We might reduce some barriers, but we may be introducing other forms of barriers. So I want to talk through a few of those in terms of what that might look like and how we might be ahead of that in terms of moving forward with our telehealth solutions. Next slide, please. Could I get the next? There we go. Perfect. So one of these umbrellas is design considerations. So for the most part, telehealth solutions are designed with what I would call the average user in mind and not focused on those who have been historically marginalized and rather really focused on more of a majority population or an average user population. And so the ways to be thinking about the importance of this is to be as proactive as possible in our design processes. So one of these is certainly compliance with existing standards and best practices. I talk about existing standards, existing guidelines. That might seem kind of like a no-brainer, but certainly we know that doesn't happen in practice in many cases. And so it's on all of us who get to make selections about what technologies we use to really make sure that we're choosing those systems where that has been a part of the process. The other part is in terms of best practices of human-centered design. And this is really about, in a design process, often there might be usability testing that occurs at the end of a design process for someone to give feedback towards the end. But at that point in a design process, we're really at the point where we can make small changes to the design that's already been developed because of the cost of going back and starting over can be so prohibitive. And so the importance of all of us to advocate for people with disabilities to be involved in the design practice early on to ensure that needs are getting met when it's not so costly to implement those needs. So this is certainly responsiveness to individual needs as a part of that. One of the examples I like to give is when we started with synchronous telehealth, many systems were designed for one patient and one clinician and not attentive to the fact that there might be 3 or 4 or more people who are not co-located that need to be a part of that appointment. And so this is one example of what I talked about really early on in terms of functionality that might need to be different for a non quote unquote average user. And then responsive to individual needs, when we think about patient portals or things like MyChart, often there's one mechanism for communication. So MyChart, right, the kind of default for a lot of these is to have a text-based communication, but perhaps there's ways to have audio files that we can exchange as well. And so just thinking through how do we create multiple modes of interaction when we're engaging in design. Next slide, please. Another bucket relates to implementations. We've talked a lot about expanding broadband access. So I'm not going to dig into that. Another intervention has been that some clinics have done is providing access to accessible technologies. And the bullet point that follows that's really related to this is then training both patients and clinicians on how to do this. The analogy I like to give sometimes is the Wings for All or Wings for Autism program that the ARC runs. And in terms of this, really the idea here is when individuals are going to go through the TSA screening at airports, that there is this opportunity to engage in a rehearsal, to learn about the plane features, the safety protocols, how you receive a boarding pass and go through security. So really going through the whole process as a dry run ahead of time and thinking through how might we adopt and adapt a process like that in the context of telehealth so that both patients and clinicians feel ready to engage, know how to enable any accessibility features that need to be enabled, and so that the focus can really be on the interaction that needs to take place. Next slide, please. And the last in a bucket here is, of course, around policy considerations that we've been talking about today, and again, in some depth. And so one is really this advocacy for us around developing and enforcing the clear and comprehensive standards for web accessibility, for mobile health accessibility, and for the need to keep evolving towards more specific and more comprehensive guidelines in that space. The other point I'd like to make here is really related to thinking about how we monitor health and patient-centered outcomes by disability status and disability type. Certainly a part of this is our need to do better in terms of collecting disability-related data within our health systems. There's a lot of conversations happening around that currently, and still a lot of movement that needs to happen in this space. But until we're able to monitor those types of outcomes, it's really hard for us to know whether we're exacerbating these disparities or if we're creating advancement and trying to eliminate those, and the role that telehealth is playing, regardless of which direction we're moving. Next slide, please. So I'm going to end, I think I have 5 minutes left. I'm going to go through this fairly quickly, but what I wanted to conclude with was a framework that I developed with several community partners in the context of trying to create accessible digital health technology. And these are lessons that we tried to synthesize from multiple grants that we had that were supported by the Agency for Healthcare Research and Quality and NIH, but also from advocacy work that I and everyone else who was an author on this have been doing for some time now. And thinking about community partnerships is foundational to thinking about how we're designing our telehealth solutions, how we're implementing them, and of course, how we're guiding policy around them as well. And what I'd love, and I know in the context of this conversation, in terms of questions, I would also love feedback on the framework that we've developed. If you think there are things that are missing or that you don't agree with, this is out in the world, but I think of it as, part of our continuous learning about how to do this better and to share those lessons learned with others so they can also, particularly developers and those that are doing implementation, can think about this in their work. Okay, so the first thing that I often like to talk about is the importance of understanding the broader disability context. Certainly since NIH has designated the disability community as a health disparity population, there's more and more people that I've been engaging with across a wide range of agencies and foundations and vendors and many others in terms of getting into this work and doing it well. And here it's really about the importance of trying to understand the historical context of research and development as it relates to working with the disability community and other intersecting communities. I often talk about the importance of becoming familiar with debates in the context of our community and also understanding what the conversation looks like about moving from a medical model that is still very much in the context of health sciences and developing of health information technology, often the focus, and moving toward that social model of disability. Next slide, please. The second is really this partnership with community members and nothing about us without us, the importance of developing strong relationships with community organizations and across types of disability, given the heterogeneity of our community, and engaging the community throughout all aspects of the research or development and implementation process. So from understanding needs and priorities all the way towards what I was talking about earlier on in terms of implementation and monitoring both intended and unintended consequences. Next slide, please. In doing any type of testing or dry runs or trying to understand in terms of a pilot, what's working well and not working well, again, the importance of purposely sampling across people with a wide range of diagnoses, a wide range of functional abilities, and a wide range of disability identities. And I often try to also talk about this in terms of how do you put some of this into practice? So thinking through the ways that we may reach out to community members to engage in this work with us. So the importance, of course, of using audio, text-based, plain language oriented materials to make sure that everyone is aware of the opportunity to engage in this type of work, as opposed to, again, focusing on an average user and kind of the average way somebody might go about learning about the opportunity to engage. Next slide, please. So here's about creating responsive and accommodating study procedures. And what I'd like to highlight here is the idea of coming prepared with alternative approaches. So in one of the assessments we did, we were looking at some different mHealth apps that are in that umbrella of telehealth, and thinking through how we get feedback when people took these apps home to use in their everyday life. And we were really interested in, hey, you can create a voice memo and send that back to us. We can call you on the phone to get your feedback. We can engage in text messages with you. You can write on a piece of paper and you can mail it to us. So really trying to think through, again, how do we create access as we're trying to get feedback about what's working well and not working well. Next slide, please.
We're right about at time.
Yep, I have one more slide after this. So I'm almost done. So this last one is about building foundations for future work. So here again, just thinking through how we encourage and build capacity for more people with disabilities to be involved in the design process, in implementing telehealth solutions, and really thinking through, again, looking forward, what do we need to do to build capacity to keep this moving? Next and last slide, please. So here I'm really just leave you with this idea. I think this is really important, of course, but also complex work. We talk a lot about transdisciplinary efforts at multiple levels. And I always just want to highlight how important it is for this partnership with our community as a part of everything from design to implementation to policy development. So thank you, and I'm happy to take questions.
Wonderful. Thank you very much. We did get a question that is in two parts. And
Okay.
so the first part of the question is technology and science a hindrance depending on where you live in Virginia? So for instance, are rural persons more or less skeptical than, say, urban or suburban people?
That's a great question. It's a big question. So I don't know that I have specific numbers, and the scientist in me wants to see right what the numbers are. I think I can only speak to my own experience and engagement. And I would say, I've done work with people living in rural communities, in urban communities, and in more inner city communities. And for me, the work has really been about the relationship, and that the relationship has then fostered engagement in that science and technology. So whether that work has been in our public, I do a lot of work in our public housing community here in Charlottesville, and have done work in Richmond as well, and then have done work in West Virginia, for example, in Appalachia. And in all of those cases, for me, getting the honest and what I would call honest and actionable feedback and developing research and science ideas together has been about the multiple years of engagement that happen before the specific research questions, for example, are posed, as opposed to coming in and saying, I want to do this work, will you engage in it?
Okay, very good. I have a follow-up question, and it was more, did any recommendations come out of your findings that 35% of practitioners were familiar or had little knowledge about the Americans with Disabilities Act? It was in one of your earlier slides.
So that's a study that was conducted by a colleague of mine. So it's Lisa Iazoni's work out of Harvard, that she's done that work, that over a third of physicians claim to little or nothing about the responsibilities under the ADA. It's a fairly recent study, so 2022. So it's not that there's been, significant kind of broad movement about that. I would say there are efforts in different spaces to try to address that. So again, speaking to some of the work that we're doing at UVA, we've created a training that allows physicians to learn more about this, about the disability community as a health disparity population, the barriers that are faced by the community, and then moving towards this. So we've done one of a series of trainings that we're in the process of finalizing and rolling out. So that's all to say, I would say absolutely a work in progress, and we're not where we need to be at. And I think a lot of opportunity to do work in this space. And the other thing I would say is, at least for us, we've revamped all of our School of Medicine curriculum so that disability is a part of every class now as a part of the conversation. And again, that's been a committee of us led by some incredible med students who've really pushed that forward.
Well, that's fantastic. Dr. Penny, that's all the questions that we have right now.
Thank you so much, Dr. Valdez. Thank you so much for the information that you've shared. I'm going to ask if Dr. Hughes and Attorney Jennifer can turn their cameras back on, and I'm going to yield for a few minutes to our Executive Director so that she can express on behalf of our agency what her heart feels. We are so excited to have had all of these institutions represented today. Jen even mentioned in her presentation that we have a relationship with Virginia Tech, Johns Hopkins now, and certainly the University of Virginia, along with our own state Developmental Disability Council for the state of Virginia. And it is exciting. We know it's a lot of work and it's a lot of information that we have given to you. So please rest assured that we will share our recording today. We will share the PDF PowerPoint presentations, and we are encouraging you to please go to the Virginia Board for People with Disabilities website, because we are on Facebook Live and this information can be duplicated. Let me yield to our Executive Director, Terry.
I thank everybody for attending today. It's really important information. And, we all work across such a broad landscape, with so many different needs, so many different barriers that we're trying to address, and really trying to understand how we can have an impact. And the information that we heard today really educated me. I mean, we did our own assessment on geographic disparities with a focus on telehealth. But my knowledge and understanding was enriched today. And I thank you to all of our presenters and your expertise and your work in this area that is really, changing healthcare in a way that makes it more accessible and meaningful to people, people with disabilities and others, people with other, disparities that impact their ability to access healthcare. So I just appreciate everybody's work, and just really happy to connect with you. And thank everybody for participating today, and Christine and Dr. Penny for your work, and Jen, great job with your presentation. So thank you all.
I also want to acknowledge our members of our training alumni, and I want Dr. Hughes and Dr. Valdez to know that, as I stated at the very beginning, this is the mission work of our training alumni. They are all graduates of one of our two training programs, Partners in Policymaking training program, and or our Youth Leadership Academy, which was formerly known as the Youth Leadership Forum. And I'm so happy. I want them to turn on their cameras so we can see their faces. Catherine and Marlo, I see Debbie Stakunis, and I see Sohail, and I see Kelly Vanella, who are all here. They are our alumni. I want you to know that all of these topics, statewide topics, we get together in retreat form, and they as alumni leaders come up with these topics that they feel are necessary for us to address and to educate and to inform our constituency about. And so this work is not done without the work of our alumni. And we just want to celebrate you guys and thank you so much for all the work you do to help us bring these to the public. So Debbie, I see you. No comments from you? We're going to bring up the poll, the evaluation poll for all of the participants who still remain with us. If you could complete that poll for us, we would appreciate it. And then I'm going to ask Christine at the same time if she could bring up our marketing piece. That I just want to let our audience know that in this year, we have 2 more statewide sessions that remained, and we have 3 additional sessions in 2025. And so on October the 23rd, we have a statewide session on transition options, deaf community services, accommodations for college students, and alternative hiring processes. That is October the 23rd. It is a Wednesday from 6 p.m. to 8 p.m. On November the 15th, we have another statewide session, Planning for Life with a Disability, Financial, Legal, and Support Strategies. And that is Friday, November the 15th from 12 noon to 2 p.m. In the new year, we will present in February, on the 21st of February, on a Friday from 12 to 2, Navigating Justice Part 1, School to Prison Pipeline. And on March 19th, Navigating Justice Part 2, which is a Wednesday from 6 p.m. to 8 p.m. Part 2, Safeguarding People with Intellectual and Developmental Disabilities and Invisible Disabilities. And then we'll conclude this statewide session for the state year on April the 11th, 2025, with a workshop entitled Supported Decision-Making, Protecting Rights, Ensuring Choices, and Aging Caregivers. All of our sessions have dynamic presenters, individuals who are experts in these areas, and we are grateful on behalf of Virginia Board for People with Disabilities to bring these statewide educational workshop sessions to all of you. Today, we had registered 106 persons to attend this session. We somewhere wavered between 40 and 45 persons today, but it tells us that the subject matter is of interest to many, that the timing does not always work for everybody, that life happens on the day of the event, and also that it is important for us to record and to provide it on our Facebook page so that many others can access it. And we do have data that proves that many folks after our events go to our Facebook page and they are actually accessing it. So our numbers increase. On behalf of Virginia Board, thank you, Dr. Hughes. Thank you, Attorney S.E. Jennifer, and thank you, Dr. Rupert Valdez, for all of your time and your energy and for pouring into us on behalf of the Commonwealth of Virginia. Have a good day.